So good evening, folks. Welcome to the HPCSA Booklet 10, The Hidden Liabilities of Telehealth webinar offered by EthiQal tonight. My name is Amy Wolf. I am your host, and we have a full program planned, so let's get started. From a disclaimer perspective, this is a conversation between stakeholders. We're not offering any legal advice. We're purely sharing our perspectives, and the case studies you see will be fictional. Any resemblance to actual cases is purely coincidental. From a general housekeeping perspective, questions can be raised through the Q&A that you are able to choose whether you are anonymous or not, or the chat function. There will be a series of multiple choice questions. Your answers are anonymous, so please give it a stab to test your knowledge. And if you're joining via the browser on your mobile, you will need to answer in the chat or log in on the Zoom app to vote. If you attend the full webinar, you will get 2 ethics points and your CPD certificates will be sent within 4 weeks. There will also be a video recording available from Thursday, the 18th of December on the EthiQal website if you want to go back and rewatch it or share it with a colleague. I'd also like to welcome tonight's subject matter experts who will form part of our faculty and panel. Firstly, Dr. Simon Strawn. He's a practicing pediatrician based at Life Bedford Gardens in Johannesburg. He serves as the CEO of the South African Private Practitioners Forum and represents over 4,500 specialist private practitioners nationwide. Under his leadership, the SAPPF actively engages in health policy discussions, striving to improve the quality and access to healthcare services in South Africa. He is also a steering committee member of the Universal Healthcare Access Coalition that advocates for practical solutions to access universal healthcare coverage for all South Africans. Dr. Shlombi Makaluma is a general medical practitioner with a master's in medical law and ethics. He's currently a PhD candidate in medical law at the University of Pretoria. At EthiQal, he provides medical legal advice on various issues affecting the doctor, from general advice through to claims, complaints, and notifications. He is the interface between the doctor and the legal and risk management processes. Then Kate McKay. She is a senior associate at Clyde & Co. and specializes in litigation within the healthcare professional, indemnity, and insurance sectors. She has advised and represented a broad spectrum of clients, including leading insurers, specialist medical practitioners, and private hospital groups. Her practice focuses on complex medical malpractice claims, representations to various regulatory bodies, including the HPCSA, the OHO, and SANC, and other professional indemnity disputes. She holds a Bachelor of Science in Human Life Sciences and Psychology, as well as an LLB. And with the strong foundation in both science and law, Kate brings a unique interdisciplinary perspective to her work, which enhances her ability to engage with medical experts, interpret clinical evidence, and navigate the intricacies of healthcare-related litigation with precision and insight. And then Suren Govender. Suren is the Chief Operating Officer at iGuard SA, a leading 24/7 managed cybersecurity service provider that protects critical infrastructure for healthcare environments across Africa. With over 30 years of experience in technology, digital transformation, and cybersecurity, Suren has been instrumental in shaping how organizations safeguard data, build trust, and navigate the risks of digital care delivery. As the former Chief Digital Officer at Life Healthcare, he led the organization's digital transformation and the incident recovery following one of South Africa's most significant healthcare cyber attacks, and provides first-hand experience of the ethical, operational, and patient impact dimensions of digital health risk. He now lectures on cybersecurity at Henley Business School's Future-Proof Your Healthcare program, helping healthcare professionals understand how to embed cybersecurity and privacy principles into ethical clinical practice. He also serves as a founding board member of the Cybersecurity Digital Alliance. Drawing from his cross-sector experience, including that at financial institutions, Suren brings a balanced perspective to the discussion on telehealth ethics, emphasizing the intersection between technology, human care, and regulatory compliance. His mission is to help healthcare professionals harness the benefits of digital innovation securely, responsibly, and ethically. Thank you all for joining us tonight. We're looking forward to hearing your various perspectives. And now we want to know a little bit more about you as our audience tonight. So I'd like to invite you to participate in a series of introductory questions. These will come up on your screen one by one, and you'll be able to answer in the poll if you're joining on your laptop or on your tablet. If you're joining on your phone and you haven't connected through the app, you'll need to put your answers in the chat, and you will be able to vote anonymously. So let's get started on that. So the first question is, I am a medical student, a GP, an allied health professional, a specialist, a practice support staff member, or you fall into another category. Brandon, if you can please bring up the poll for us to vote. Thank you very much. So we'll give you about 20 seconds to vote. Okay, that's looking wonderful. Okay, remember, if you're struggling to vote, you're welcome to put your answers in the chat. All right, that's looking great. Loving all this interaction tonight. Okay, Brandon, if you can close the polls for us. Okay, so interesting to see that 58% of our audience is specialists, followed on by allied health professions. Okay. Next question. I have been in practice for less than a year, 1 to 5 years, 5 to 10 years, 10 to 15 years, more than 15 years, or other. Brandon, if you can please bring up the poll for us. Thank you to everyone to responding in the chat. All right, if you'll vote. Okay, looking great. Okay. Wonderful to have such an interactive audience tonight. Okay, Brandon, if you'll close the poll for us. All right, so more than, well, 63% of you have been in practice for more than 15 years. And the next closest group is 10 to 15 years. So we're hoping we can share something new with you tonight. All right, I work in the private sector, the public sector, both the public and private sector, or other. Brandon, if you can bring in the poll for us, please. Okay, if you please vote. Remember, if you're new and you can't vote, you're welcome to put your comments in the chat and we'll pull those up. Okay, looking great. Okay, majority of you are working in the private sector. Okay, closely followed by both public and private. Okay, remember your answers are anonymous, so you're welcome to fill in here. Okay, lovely. Brandon, if you can close for us, please. All right, so 69% of you are in the private sector. Okay, and then your last question. I use the following telehealth options in the consultation of my patients, and we're asking you to please choose one, the one that applies to you the most. So option 1 is none at all. I only consult patients face-to-face. Then face-to-face consultations with predominant use of video platforms, example Zoom or MS Teams for virtual consultations. Option number 3 is face-to-face consultations with predominant use of social media, so WhatsApp and Telegram for virtual consultations, or face-to-face consultations plus or minus the use of video platforms or social media with the use of a dedicated telehealth platform, example Telehealth at home, in the virtual consultation of patients. And then the last option is I do not see patients face-to-face, I only consult via telehealth. Brandon, can you bring up the last poll for us? Thank you. So if you will vote for the option that applies to you predominantly. Okay. Currently seeing the majority of consulting only face-to-face. Interesting. Okay. Okay. And very few only seeing patients via telehealth. Great. Okay, Brandon, if you'll close the poll for us, please. Thank you very much. Okay, it was wonderful. And now we're going to test your current knowledge with our first case study. So, Shlumbi, can I hand over to you to introduce the first case study, please?
Thank you very much, and good evening, everyone. This is our first case study. This is something that is very common. Dermatologist receives a WhatsApp message from a patient last seen 18 months earlier, and the patient shares a photo of a skin rash, asking, "Doc, can I get something for this?" Doctor issues a prescription for the topical steroid. The rash worsens over the following days and is later diagnosed as shingles. Due to delayed antiviral treatment, the patient suffers from prolonged neuropathic pain, and as we expect, the patient complains to the HPCSA and saying that the dermatologist was negligent in the teleconsultation, could have shared more, could have asked more. That is a very simple thing that happens to all of us.
Wonderful. Thank you, Shlumbe. Okay, so let's move into our questions. Question number 1. Which of the following best reflects the doctor's ethical obligation before prescribing a treatment via a telehealth platform? A, the doctor can rely on past consultations to justify remote prescribing without reassessment. B, the doctor must ensure an adequate clinical assessment, which may include video consultation or referral for in-person review. Or C, the doctor may prescribe based solely on a photo if the patient requests urgent treatment and is a patient who has once visited the practice. Brandon, can you please bring up case study 1, question 1 for the audience, please? For those of you who've just joined, your answers are all anonymous. So even if you're not sure, please take a guess and test your knowledge. A, B, or C. Okay, we're going to give you a few more seconds to vote. Great to see so many of you voting. For those of you who cannot vote because you're accessing on your phone, you're welcome to put your answers in the chat. All right, we're getting a few more answers coming in. I'll give you another few seconds. Looking good so far. 91% are saying the doctor must ensure adequate clinical assessment. All right, Brandon, if you can please close the poll for us and show us which was the right answer. Wonderful. So the majority of you got it correct. The answer is B. Okay. Question number 2. What is the doctor's responsibility regarding informed consent in this teleconsultation scenario? A, the doctor must ensure the patient understands the limitations and risks of remote care before proceeding. B, consent is implied when the patient initiates contact via WhatsApp. C, consent is unnecessary if the doctor believes the treatment is routine and the patient is literate. Brandon, can you please bring up case study 1, question 2 for us, please? Okay, we invite you to vote. Okay, for those of you who've just joined, your voting is anonymous. Even if you're not sure, please give a guess, test your knowledge. And if you are unable to vote on your phone because you're accessing via your browser, you're welcome to put your answer in the chat. All right, looking really good. Okay, a few more coming through. Wonderful. Okay, Brandon, can you close our poll for us, please? Let's see what the correct answer is. Okay, the correct answer is A, which 95% of you got. So the doctor must ensure the patient understands the limitation and risks of remote care before proceeding. And now question 3, what legal or ethical risk does the doctor face under HPCSA guidelines following the patient's complaint? A, the doctor is protected from liability because the patient initiated the teleconsultation and accurately described the rash. Or B, the doctor may be found negligent for failing to recommend an in-person review and not keeping any records other than the WhatsApp screenshot, breaching the standard of care. Or C, the doctor's liability depends solely on whether the rash was misdiagnosed. Brandon, can you bring up case study 1, question 3, please, for the audience? We invite you to vote, test your knowledge. Great to see so many of you being so enthusiastic to respond. This is looking good. If you've just joined, your answers are anonymous. You're welcome to take a guess if you're not sure. And if you are unable to vote on your phone, please feel free to put your answers in the chat. Okay, we'll give a few more seconds for those of you who are still considering your options. Okay, Brandon, if you will close the poll for us and bring up the correct answer. Okay, so the correct answer is B. The doctor may be found negligent for failing to recommend an in-person review and not keeping any records other than the WhatsApp screenshot, breaching the standard of care. And wonderful to see so many of you getting that correct. All right. So, Dr. Strawn, I'm going to stop sharing now, and if I can invite you to share your presentation.
All right. Thanks very much, Amy, and thanks to the rest of the faculty. Nice to be working with you. Some of you working with you again. So I'm one of the majority. I too am a specialist. I'm a pediatrician. I've been in practice for 30 years. I'm in private practice exclusively, and I predominantly see face-to-face patients. Now, the complexities of this guideline are quite clearly highlighted in that first scenario. Because just picking out three things from that first scenario. The one is, did you ever imagine that a WhatsApp from a patient would be covered by this book called The Good Practice in Telehealth? I'm sure most people think that this is to do with virtual consultations where you sit face-to-face on video. Well, it's not. It's any form of communication. And with that, this first scenario highlights the need for a full examination of the patient. It highlights the need for consent from the patient, and it highlights the need for record keeping. So the purpose of the guideline, everything you see on my screen is taken directly from the booklet. So if there are typos, spelling errors, grammatical errors, that's the way it is. The important thing about this is that none of these guidelines should be read in isolation. So this guideline on telehealth, you need to look at it with regard to general ethical guidelines, patient consent, confidentiality, and keeping of patient records. So we've done a webinar before on keeping of patient records, and whatever applied there applies here. The security that you need for your patient records, your electronic health record system, or your room with 30,000 files, it all applies to everything you do. Every discussion that you have with a patient over whatever medium it is forms part of the patient record. Every interaction with the patient is part of that clinical record, regardless of the modality that you use. Now, what's interesting about these guidelines, the way they are written, is it's really trying to guide you to say you're using telehealth because of the inequity to access in healthcare in South Africa. So it is to administer healthcare services in two geographic separated locations for the purpose of facilitating, improving, and enhancing clinical education and research, particularly in the underserviced areas in the Republic of South Africa. And telehealth is a blanket term that covers all components and activities of healthcare and the healthcare systems that are conducted through telecommunications technologies. That's why I put all the telephones there. Telehealth, telephone. Even if you're having a conversation with a patient on a telephone, it is regarded as telehealth. And everything that we say tonight, everything within the guideline, you need to apply that to even the conversations you have on the telephone with your patients. So obviously, when we're talking about using social media and social media platforms and transferring any form of information, medical information, it includes every social media platform you could imagine, as well as SMS, emails, electronic journals, internet discussion forums, anything at all where patient information is being shared, whether it's anonymous or not, is regarded as telehealth, and you have a responsibility to your patient whose information you are sharing, and to the and further to the patient, the responsibility to keep that information confidential and secure. So the reason I highlighted this was just again to say any suitable information communication technology platform, such as cellular phones, telephones, Skype. Okay, so it's every single thing that we do. It's not just secure video conferencing and virtual consultations with the patient. And this whole thing, although telehealth has become an essential tool in alleviating human resource crises, it also raises important ethical and legal issues that practitioners carefully consider. And 3.3, when using telehealth, all principles of good practice in relation to patient consent, confidentiality, and good record keeping still apply. And that's what's really been highlighted in this first scenario. And I think we need to really chew on this stuff and digest it and understand how we truly implement that in our practices. Because I don't know about you, but the number of patients a day that I speak to on email or WhatsApp or telephone, and we're supposed to keep records of every single one of those consultations because they form part of the patient record. And if the patient's unhappy, they're going to go and report you, and you're going to have to produce the record. It is desirable that the practitioner shall have established professional relationship with their patient before telehealth services can be considered, although this is not a compulsory requirement. Not a compulsory requirement when it's in an emergency situation. But otherwise, you need to do this. So in my practice, we run a WhatsApp group for all our patients, and there are three pediatricians on that WhatsApp group. So patients come in, and very often we'll get somebody asking a question. We have to go back and say, sorry, who are you? Which pediatrician have you seen? And if they're not members of our practice, we have to say, we're not prepared to talk to you. And then obviously we can talk about how we secure that line. And interesting, no practitioner may exclusively render professional services through telehealth. So you can't be just a telehealth doctor. You actually have to see patients face to face. And this is important. In the case of telehealth across country borders, you have to be registered in the country, in South Africa, and in the country where you are giving that advice. I was approached about 4 years ago to join a group in London who they wanted pediatric consultations for their clients in London. And I got quite far down the line with this group. It looked like going to be a really nice source of revenue and a very good source of a thing to keep me going. Until I came across this when I went and asked actually around authorizations. So you can't just be giving advice across borders. You actually have to be registered in both countries. And practitioners are held to the same standards of professional practice as healthcare practitioners who conduct face-to-face consultations. All right, I've stressed this enough. It's really important that we all understand it. Now, this section 3.4, 3.6 takes a slightly different view of this. This is saying don't use standard social media platforms. In other words, try not to have a one-on-one patient on a WhatsApp, which is on your personal number with them on their personal number. Because you know what happens. I mean, we've seen it all the time. You send the wrong picture to the wrong person, and then everybody knows about it. And then you may start sharing information that, in fact, you're not supposed to be sharing, or the patient may be sharing information with you that is not appropriate. And, we need to be looking at POPI. And remember that POPI says that it outlaws the acquisition of data about an individual's personal, as I said, this is what's in the book, their personal information, including health, outside of a healthcare setting. So how do you make these social media things then if you are going to use them part of the healthcare setting? Well, that's where the consent comes in, and we'll talk about that in a minute. But this is really warning against the easy, quick use of just quickly pop a WhatsApp. So if patients have your personal number, and suddenly 11 o'clock at night you get a WhatsApp of a rash, and you're looking at this thing, and now you've been blue ticked. The patient's seen that you've seen it. I mean, I'd love to kind of explore that, to go, the patient now knows that you've seen it, but you haven't responded. And and if you've got a habit of responding previously and this time you don't, you just get yourself into too much problem. Now, I want to go to the next step of this, because what we've spoken about up to now is that relationship where you are dealing with your patient. The patient that you're doing it either video, you've set up a proper video thing, or you're doing it on WhatsApp, or whatever it's doing. But the next section here is around between professionals. And the terminology used, there's a description in the guidelines about practitioner in charge, and there's another description about the consulting practitioner. So that would be the person that you're getting hold of now because you've got the patient in front of you. But then suddenly in the document, you'll see suddenly things like servicing practitioner pop up and consultant practitioner pop up. So the definition, it's a bit of a mess, the document. It's fairly self-explanatory. I mean, they're all referring to the practitioner in charge, but I'm just warning you that they're using different terminologies. This is a very important point now. It's about who actually assumes primary responsibility. You know, and for me, I'll use my own example. It's like I'm lying in bed at night. It's 1 o'clock in the morning, and I get a phone call from the casualty officer at the hospital where I work, and then I want to discuss a patient with me. And you know what is going to happen is that that casualty officer is going to write in the clinical notes, discussed with Dr. Strawn, and this was the decision taken. So if that is what's going to happen, that doctor is assuming the primary responsibility. And I, as the consulting practitioner, have to do what? Securely keep detailed records, online or otherwise, of the professional services. Make sure that you understand everything about the patient. Make sure that you have got as much information from that doctor who's asking for your opinion as you possibly can get out of them. Make sure that when you give advice, the doctor understands the advice. Make notes, record everything, preferably record it like audio, record it, or at least make clinical notes. That's what this is saying. But it's 1 o'clock in the morning. And it's probably the third time it's happened, and there might be one or two more through the night. Guidelines are guidelines. I'm just presenting to you what's in the guidelines. We need to take heed of this and understand how we implement it in our practice. Now, the considerations of telehealth, this talks now to the first scenario. Look at what the guidelines are saying about when you decide to do a remote consultation rather than face-to-face. And remember that any form of telehealth, you need to be trying to replicate the quality of information and quality of interaction as if it were a face-to-face. You're trying to replicate that. It's not replacing it. It's acknowledging that in this instance, I cannot get to the patient. That doesn't mean there is less information required or that there's a lesser responsibility of duty of care demanded of us as the providers. So when you're deciding to say, hey, listen, let's do it face-to-face, think about the need for review or to assess the severity of symptoms, physical and physiological. Previous knowledge for the patient client. You know, if you don't have access to the records and now you're flying blind because you're not in your practice and you don't have access to electronic health records, and it's a patient of yours, how are you going to handle that? The need for a physical exam, if you feel you need it. And as I said, the triggers, you need to look at the triggers that would drive you to get a good face-to-face, because it's good practice for practitioners to consider the social circumstances as well. So in other words, it's literally you have to think about everything that you would get from a face-to-face before you go, okay, we can do this virtually. So evaluation and treatment of patients in a telehealth situation. Documented medical evaluation must be done and the relevant clinical history necessary to diagnose underlying conditions, as well as any contraindications regarding the recommended treatment, must be obtained before providing treatment, including issue prescriptions or electronic or otherwise. The treatment, including issuing a prescription based solely on an online questionnaire, does not constitute an acceptable standard of care, like we heard in scenario 1. When prescribing care using telehealth, practitioners should ensure that expressed informed consent in accordance with the standards practiced in face-to-face issuing of prescriptions. This is a big demand on something that we do all the time. It seems like it might be a little easier if you've got a very secure setup and you're doing regular video consults and you've got a platform and everything's recorded, you get consent signed. That stuff is easier to manage in terms of what we're dealing with here, but it's the day-to-day stuff. It's also remembering this situation now, when you're phoning a colleague, it's not just about, we just phone them and say, hey there, it's me, it's Simon, how are you doing? Can you give me, got 2 seconds for me, 2 minutes for me, blah, 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 quick, chat, thanks very much, boom, done. We do that all the time. The servicing healthcare practitioner should verify. So here it says the servicing healthcare practitioner, which is not defined, but this would be the consulting practitioner, the one that you as the primary person are calling. Location of the consulting healthcare practitioner, the identity and qualifications of the consulting practitioner, the identity of the patient, the location of the patient, to know that whether proper informed consent has been obtained. Now, in that informed consent for the use of telehealth can be obtained in writing or recorded orally. An informed consent documentation for telehealth should include the following: the identities, agreement by the patient that the practitioner is the one to decide whether the condition being diagnosed or treated is appropriate for telehealth. That's up to us. The practice number, the types of transmissions consented to using technologies, details of the security measures taken with the use of telehealth, and any material risk to confidentiality arising from the use of telehealth. This is part of the informed consent. And like you had in scenario 1 where the dermatologist will send a photograph, if you really are going to engage in that kind of advice and you want to have a watertight case in terms of consent, the guideline is suggesting this is what we do. This is my last slide now, just to talk about security. Patient information should only be transmitted from one site to another and stored with the full knowledge and approval of the patient in line with informed consent guidelines. Only the information that is relevant to the clinical history of the patient should be transmitted electronically. So in other words, it's consistent with the POPI requirements that you only share the information that is necessary. To protect, here's the kicker, if you're going to be chatting to another colleague, to protect the identity of the patient when information is transmitted between sites, it is essential that personal identification should be removed and that transmitted information is encrypted. Okay. There were two things in that statement. The first was remove the identification and the transmitted information is encrypted, at the very least password protected, so that when you're transferring it, the person receiving it has to unlock with the password. All personal computers of telehealth services should be accessed by authorized personnel only through use of a login password. So the WhatsApp group that I run in my practice, we have it on our computers, and our computers obviously have dual authentication to access it. And the phone that carries the WhatsApp, that is also dual authenticated. You need a fingerprint to access the telephone, and you need a fingerprint to access WhatsApp. And the moment you stop WhatsApp, it closes immediately. There's no lag on it whatsoever. So if the phone gets stolen, nobody can access it. But still, we run the risk of sending the wrong photograph to the wrong patient and ending up with problems. There are three factors central to the security of patient information, namely privacy, who can access it, who sends the information, has the information been altered during this transmission through the public networks. So that's about security, making sure confidentiality, making sure that there is consent, because all of this around this, the patient has to give consent. So that, in a nutshell, is the booklet. So let's proceed, and hopefully some of this will unpack as we go along, and we can chat about it later on. Amy, thanks. Let me hand back to you.
Thank you very much, Dr. Strawn. That was very informative, and I'm sure the audience appreciates being able to orientate about what is covered very briefly. So we are now moving to a panel discussion. Brandon, can I ask you to profile everyone on the screen so we can see all the faculty members? And I'm noticing that we have some good questions and comments coming through in the chat function. Shlumbi, would you like to choose the first one that we're going to cover?
Yeah, I just want to look at the question around momentum. Hello, doctor for patients. It's an interesting question in a sense that you don't have a responsibility if you have not given an advice as a practitioner. Even if you know that patient, if I decide to call a certain line and I get advice as a patient from a certain doctor who's sitting somewhere, it is that doctor that has the responsibility. It's got no bearing on any other doctor that was not involved in giving the responsibility. I think for me, the other thing that I just wanted to highlight from, Dr. Strawn's presentation is at a practical level, there are those things that we forget as practitioners. Firstly, Dr. Strawn will know this. My child's pediatrician is so-and-so. Now he's looking after my third born or my third child. My gynae is so-and-so, my GP is so-and-so. Even ourselves as practitioners, we tend to know these are my patients. Now, the important part, especially in the first case, is understanding that although this is a patient that you know, the treatment episode would be new. Unless you're dealing with that person as a continuation from when you saw the patient before. But in this case, the last time this dermatologist saw the patient was 18 months. But you know this person. This is a person that is known to this practice. It is easy for the doctors to say, oh no, I know Suren is a patient of this practice. Therefore, when he speaks, then I'll give him whatever he wants. And we forget about the proper informed consent. We forget about taking records properly to get all the conditions, all the prerequisite, though not desirable, it's just desirable, not enforced, to say, let me see you. I think the trap that we get into is familiarity between ourselves as practitioners and the patients that have been coming to our practice for a long time.
Thanks, Hlombe. Dr. Strawn, do you want to touch from a clinical, practical perspective? What are you seeing?
Yeah, so I think just following on from Hlombe, I mean, he's making a really good point. And it is difficult when we get these very pragmatic, very detailed guidelines from the HPCSA. And it's very clear. Kate, I'd love to hear your opinion on this. It's very clear to me reading the guideline that the guideline was written predominantly with two things in mind. The one was arranged video conferencing with patients who are at a distance and don't have access. But more importantly, and the guideline is not well written, but I mean, more importantly, to govern the regulations of two practitioners. Somebody sitting in a neonatal ICU with a tiny baby calling a neonatologist in a quaternary center going, I need your help, to govern that. And yet we know when you read it, they go right down to saying any telephone call, any WhatsApp, anything. So, it's like, let me put the question to you, Kate. Let me put the question to you. The whole thing about what would the reasonable doctor do? Okay? I mean, how does that apply with the guidelines that we have now?
Yeah, and the guidelines create confusion. That's it. I mean, the fact that it's too broad and not specific enough creates this very difficult web for you doctors to be trying to find your way through. I mean, it's on the one hand, you're saying that there is this doctor-doctor relationship. So the classic example of in the evening, you get a call from another doctor in the emergency ward who's got a clinical question. But in the same breath, the guideline seems to be dealing with the patient-doctor relationship too, but without distinguishing the two scenarios clearly enough. And I think that's where the confusion comes in, is that practically, you guys use telehealth on a day-to-day basis without even realizing it. I mean, I think the poll was like, what was it, about 72% of you said you only do face-to-face. Now, having heard what Simon's had to say, I mean, is that answer still correct? I'm sure you guys do telephone calls with one another, even between colleagues. That is telehealth. And that's what isn't so clear from the guidelines. And I mean, I don't know how it's going to get clearer. I know we all know that these guidelines tend to stick around for a bit too long without meaningful change, but interpreting them becomes problematic. Representing you guys at the HPCSA becomes problematic because of how broad it is. And that's all the more reason why you need to be stringent with your record keeping. So meeting the requirements of all the other booklets, making sure that these telephone calls that you have between your colleagues, between even your regular patients, are properly documented, because that gets you out of trouble more than anything else. The lack of that record on your side, which might then reflect in the hospital records because a nurse called you or another doctor called you, your stories might not add up. You might not have been provided with the correct picture overall when that telephone call was made. And then how does that filter into the actual clinical diagnosis and treatment given to your patient? So it is all very confusing, unfortunately. I mean, the guidelines are meant to guide us.
So can we look, Amy, is there time for me to take one more question from the
Absolutely,
chat?
Absolutely. I was going to suggest
because it talks to what Kate's talking about now, and I think we must all try and answer this. So there's that's from Liesel van Wyk. It's about in academic hospitals where consultants have a WhatsApp group and they talk about patients and juniors. So POPI, if you get proper consent that's aligned with POPI requirements from a patient, you should delineate in that consent what you are going to use the medical information that you glean from the patient, what you're going to use it for. You're going to use it to store it. You're going to use it for research. You're going to use it to consult with colleagues when that is required. All of this that's what's included in a good consent. So I'm sure you can see the question there. So I would like to suggest the answer to this question would be, as long as you have in place that level of consent with the patient, there's nothing wrong with that. But if there's no consent from the patient, I think that there's a problem. And again, it's like you're saying, the gray zone and difficulty between guidelines and implementation. But let me hand it over to you.
Beautiful discussion. Beautiful discussion. Shlombi, do you want to weigh in with one last comment from the call phase?
Yeah, I was just going to say exactly what Simon just said. And also, if it's a WhatsApp discussion, you can download and print and put it in that patient's file. So it's a record.
Yeah.
I mean, all the time we get the communication between the doctor and the patient. So you can download. It's a matter of practice that you just need to say, as this academic hospital in this particular department or in this unit, every day or every week we download, and it becomes a patient record. That if you keep those records as manual records, so it's something that can be done. I think for me, the only other question that I have, which was interesting question, is around giving advice to a person who is in the other country. Is it not dependent on that country's regulations, whether you can, because I understand that there are doctors who cannot practice in any other country if in that country they say you need to be registered there. However, the question probably should say, or we could extend that question and ask, if that patient now in that other country takes action against you as a consultant, a consulting practitioner, according to those definitions, can HPCSA take action against you? When you are not registered in that country, you are registered in South Africa, and the patient in the other country takes action against you, can HPCSA sanction you? I think that's for me the question that I would want to understand.
Well, you would be the one, you as medical malpractice insurers would be the one that should be giving us guidance on that. So I think, if I can be bold enough to say, I'm going to give you that as homework. So let's explore that. And let's make sure we try and see if we can get the right answer, Shlombi, because I think it's going to happen more and more.
I do have the right answer. Then from that perspective, that perspective would come to your policy wording. Yes. Your policy wording would be, your conditions of cover. What do they say? Are they saying that we would cover you if you practice here, there, and there? But it would also say, if you are registered in that place, if that regulator in that council in that country has registered you, but it would not cover you if you work in these other places. So your policy wording or your terms of cover, it's one of the most important things before you decide to consult in the other countries.
Thank you, Shlombi. So I'm going to suggest that we get back onto our case study 2 at this point, and then move over to Suren. We good? We can come back? Happy days. Okay, so let's do that. Let me just share my presentation. All right. Okay, so for those of you who've just joined us, we have a series of case studies that we will discuss during the session. There's an opportunity to answer some questions. So Shlombi, over to you.
That it probably is just, I'm not going to go to the detail because I think Dr. Strong has managed to talk about this in his presentation. It's this is a doctor that consults a surgeon, and the surgeon says, look, I've got this patient, and the newly qualified surgeon says, look, I've got this person presenting with abdominal pain. I need your response. How can you assist me? Diffuse tenderness, no guarding, stable vitals. And the consulting surgeon says, oh no, based on what you're telling me, conservative management. But overnight, the patient deteriorates, becomes hypotensive. Cut a long story short, the patient dies later. However, the consulting or the primary practitioner think it's called the primary practitioner in the booklet, or the
Practitioner in charge also,
the
yeah.
practitioner in charge had written in his notes as per the consulting practitioner's advice, right? But at the end, the patient dies and the patient's family filed medical negligence lawsuit against both doctors. I think that's a scenario that we have dealt with in Dr. Strawn's presentation.
Okay, so let's see what our audience thinks. So, question number 1 for case study 2. What is Dr. M's ethical responsibility when providing telephonic advice to Dr. X regarding a post-operative patient? A, Dr. M may assume the diagnosis and advise treatment without further inquiry, giving Dr. X's clinical summary. B, Dr. M can rely on the assumptions that post-operative complications from a simple procedure like an appendectomy in the hands of a qualified surgeon are rare and unlikely to require escalation. Or D, Dr. M must ensure that advice is based on sufficient clinical information and should recommend in-person review if uncertainty exists. Brandon, can you please bring up the poll for us? Thank you. So if you are new to the webinar, please, you're welcome to engage with the questions. If you are unable to answer, please put your answer in the chat. Your answers on the poll are anonymous. So even if you're not sure, give it a guess and see whether you know as much as you think you do. All right, these answers are coming through beautifully. We'll give you a few more seconds to vote. Okay, a few more seconds to vote. Okay, Brandon, if you can close the poll for us and bring up the correct answer. Right, so the correct answer is Dr. M must ensure that advice is based on sufficient clinical information and should recommend an in-person review if uncertainty exists. Great, and wonderful to see so many of you got that correct. Okay, and now my mouse has disappeared, which is always interesting. Brandon, can you close the poll for us and just remove it off my screen? I wonder where my mouse is now. Oh, there we go. Sorry, let me try again. I'm just going to stop sharing quickly. Okay, there we go. Let me do that. Okay, let's try again. Okay, question number 2. What is the legal implication of Dr. X documenting per Dr. M's advice in the patient records? A, Dr. M and Dr. X may share accountability if the advice was followed without adequate clinical context or verification. B, Dr. X has absolved a responsibility because the advice came from the senior specialist. Or C, liability depends on whether Dr. M was provided with sufficient information and Dr. X performed a reliable assessment of the patient. So, Brandon, can you please bring up the next poll question for us? Okay, so if you'll please cast your votes. Oh, there's a competition between A and C. Let's see what unfolds here. Okay, this is looking good. Thank you to everyone who's voting. Okay, looking good. We'll give a few more of you an opportunity to answer before we close the poll. Even if you're not sure, take a guess. It's anonymous. Who knows, you may just surprise yourself. All right, Brandon, if you can close the poll for us, please, and share the results. Okay, so the correct answer was both Dr. M and Dr. X may share accountability if the advice was followed without clinical context and verification. And 44% of you got that correct. Okay, and then the last question in this case study was, what ethical breach may have occurred when the patient deteriorated overnight without escalation? A, conservative management is ethically justified if initial vitals were stable and backed by advice from a senior specialist. B, failure to reassess and escalate care when the patient's condition worsens may constitute negligence, even if a senior specialist provided advice, and C, the deterioration was unforeseeable and therefore not ethically attributable. Brandon, can you bring up case study 2, question 3? All right, we'll give you a few seconds to answer. Okay, it looks like the majority of you think it's option B. Okay, wonderful. Remember, if you can't vote on the poll, you're welcome to put your answers in the chat. Okay, a few more seconds for the last few votes to come through. Looking good, and option B is still taking the lead. Right, Brandon, if you can close for us. Let's look at the correct answer. Okay, and the correct answer was option B. Failure to reassess and escalate care when the patient's condition worsens may constitute negligence, even if a senior specialist provided advice. All right, so now I'm going to hand over to Suren, who's our cybersecurity expert, and he's going to share what we need to know to keep us safe. Suren, if I can invite you.
All right, so good evening, everyone. And, if you thought it was complex, trying to align these guidelines with your practical challenges every day, try throwing cybersecurity into the mix. So 5 years ago, when I was still at Life Healthcare, we, as Amy told you in my introduction, I was the Chief Digital Officer, which meant that everything IT and technology related fell under my remit. And in the middle of COVID, we experienced a massive cyber breach. And I thought when I reflected on what to share with you, there's a huge amount of do's and don'ts, but I really had to kind of crystallize it down to a few things. So the intention is to leave you with a few practical pieces of advice, and I'll pepper that with a few examples. So, really it is to answer the question, what should you focus on? So the first thing, and this all comes from, aside from my own personal experience, both in the healthcare realm as well as in as a specialist in cybersecurity, the first thing we've got to really think about is patient data protection. Even if we reflect on the first case study, it comes across clearly. You've got to, the obligation around identifying your patient and vice versa, consent and documenting it, or documenting the engagement. So patient data protection is key because healthcare records, patient data, is the most targeted, the most vulnerable, and the most valuable telehealth asset that is out there. A couple of quick examples, and this, these examples are more a reflection of bad design versus actual hacking or a breach taking place. So in 2023, there was a mental health organization who ended up exposing 3.1 million records due to them using ad trackers. So, where you'd have Google putting on an ad tracker on your website, that immediately exposes identity and could also expose the type of activity you're engaging with. So that was a design oversight, but ultimately results in quite a severe data compromise. The reason for the heart there is a simple principle. Whether we're dealing with any human service or IT service or technology service, design in our world equals care. So we care enough that we design it appropriately and we design it with security in mind. The second thing to think about is, that, and as much as Simon's made the point that, telehealth isn't only about video. So this would apply to any mode of communication that you'd use. But think about this as being secure. The belief that once we've got tech in place, everything's fine, is actually couldn't be further from the truth. So in a very, I think, an example that scared all of us who are close to health tech. Babylon Health were, world famous for how they've innovated the telehealth space. They themselves ended off exposing, I think it was about 50 recordings of other consultations to patients. Now, this happened to be configuration in their platform, and again, it points to poor design, but also lack of attention around securing those engagements. And as much as, and I've seen the questions around, how do we deal with WhatsApps? Is it a real means of documenting? In truth, your video consult or recording thereof is also documentation of your engagement, but at the same time, exposure of that results in the same thing as exposing the patient record. So, when you are in whatever mode, and I understand that in many cases this can be, in an emergency situation, but you've got to start relying on secure channels of communication, and ensure that you are protecting both your own reputation as well as the patient's, and preserving the privacy of the information. So you probably come across the concept of encryption, and I'm not going to go into technically what that means, but let's take WhatsApp again. WhatsApp, we know, has end-to-end encryption, and it's easy to kind of stop there and say that's enough. The challenge is that while the application may have the encryption, when you do the backup into a cloud, so whether it's iCloud, Google Cloud, wherever your WhatsApp is getting backed up to, that in most cases is not encrypted. And if I were to ask you, do you know exactly where that's stored? You probably wouldn't know. Add to that, on the other side of the telephone or video call is the patient, and in many cases you would have, and I think we're all guilty of this in our families, is we share devices, or there are certain devices we use for certain functions. So even in that instance where the actual communication channel itself might be encrypted, it's going to fail the test around whether it actually is by instance of the application, whether I'm actually using my identity, or whether my daughter's name pops up while it's my face there, etc. So my recommendation around this is, and actually relating to, I think, all three aspects I spoke about already, is that yes, you may not be in a great place right now. You might feel that there are many gaps in your setup. Document those gaps and start working towards closing them. You might find it all in one platform, or you might find typically that you're going to have to layer it with a few layers of protection. So, if we think about where our true vulnerabilities lie, your endpoint, the laptop, the phone, the tablet, is literally the weakest link in this entire relationship. So we had, a case of, and this is again a very simple incident that could, or not could, I think does happen on a regular basis, is theft of a laptop. So there was a US home care company, and a nurse at the company had her laptop stolen, and that resulted in 13,000 records being exposed. Now, again, one is able to keep that data securely on the laptop, ensuring encryption of the laptop data, and a few other controls. So it really does start with firstly taking almost stepping back and understanding, what am I using? Is this an adequate device and level of security? And if something were to happen, in other words, if it were to be lost or if it were to be damaged, do I have a backup of that data? Is it secure? And if this device is stolen, is it possible for someone to get to the data or not? So they're all very practical considerations that one's got to take into account. And number 5, probably, I think everyone's biggest blind spot is around our third-party partners or service providers. The simple principle is that we should trust no one and verify always. But this might not be as simple as what I've just said. You know, well, I know it's attributed to Voltaire, but Spider-Man is probably more famous for saying that with great power comes great responsibility. And that's the crux of it, is that as soon as I offer a third party, and that third party might be my payer, it might be another specialist practice, it might be a referrer or referee, a hospital group, it might be Google's cloud, it might be whatever, right? Anyone else who is interfacing with a record that you've either acquired or you're appending or you own or you manage is in this category of providers or partners, data providers. And if you study POPI, what it tells us is that we have various roles in terms of being operators, processes, etc. So very important that you understand what is your role in the ownership and custodianship of that record. And remember, you don't just transfer that risk to your providers or to your third-party partners. It's very important to understand your role there. So I think it's always important to make cybersecurity relatable. In the realm of healthcare, fortunately, we have lots of parallels. So, you know, very much like in healthcare, where we have regular health checks for early detection, and then if we find something, or if the body finds something, the immune system identifies that and deals with the pathogens. And then ultimately, if there's treatment required and there's recovery, there's going to be an intervention, which will help us heal. Now, in cybersecurity, very, very similar. We do regular checks, which in many of you would have experienced in your antivirus running a scan, which is looking for anomalous behavior, looking for vulnerabilities, looking for software that isn't patched adequately. Once we do that, once we find that and identify it, we're able to isolate, contain, and ultimately through treatment eradicate. So I think this is a easy and relatable checklist for you to go through whenever you feel that or whenever you're doubting whether you're doing enough or not around your cyber hygiene. I think these are useful tips for you. You can take away because that's important also to leave you with something that you can implement today or tonight. And the first one is around passwords. So just to jog the mind a bit here, if you have a password that has 4 characters, we will be able to crack that instantly. It wouldn't take us more than a few seconds. Compared to where we would recommend around 15 characters, 12 is kind of you just out of the danger zone. But 15 characters, which would take I think that is 1 quintillion years. So the idea here is that we want to make it complex. We want to change it as often as possible. We don't want it to be too easy to guess or to infer from other information I might find about you. We find that it's probably easy if you look at the example in the middle there, using a phrase that might be easier to remember, changing some of the characters. But ultimately, a good password manager piece of software is what you're looking for. I mentioned backups, and these become quite critical when you're facing a ransomware attack or a cyber breach. Knowing and that you have a secure backup that is untainted. And the best way to do this is, have 3 copies, 2 of which are on different storage media, and 1 of which is in a remote location that is difficult to get to, or even not possible to get to. Antiviruses, and I know this is a very old topic, but the technology today is not just looking for virus signatures. It's also looking at behavioral activity, both of yourself and other entities. So it could be bots and websites and how they behave and interact with your devices. Social media is I think probably the biggest risk because it seems innocent enough, and we tend to share or overshare when it comes to social media. especially when it, and again, as healthcare practitioners, you're highly regulated on what you can advertise and where you can advertise it. But social media does kind of open up to be a little bit lax. So we're coming up to Black Friday. You're going to see lots of offers that are probably too good to be true, and probably are too good to be true. But while you're spending, also keep in mind that the scammers are all, this is hot season for scammers, with it starting on Black Friday, going into the Christmas season. Lots of opportunistic scammers are waiting to prey on us. Phishing, I think, it used to be fairly obvious when there was bad grammar and weirdly spelled words. But these days, with a little bit of AI and a bit of copy paste, a phishing scam can look very legitimate until you click on the wrong thing. And, as in the case of most of the attacks that we've dealt with in the past few years, these were caused by initially, as I mentioned up front, poor design, poor configuration, poor management, and then later down the line, someone clicking on something that they shouldn't have. Updates are critical. I know they're annoying, but if your system is asking you to do the update, do it as soon as possible. And the final point on this is, in cybersecurity, we adopt a principle called zero trust, where we trust no one, meaning every single transaction or interaction requires a new verification. So hopefully these few tips are useful for you in your practices right now. But if you go back on those five key elements that I spoke about, that's going to help you, in a little bit longer term, because you're potentially going to have to revisit the technology you use and reassess the actual risk you're facing there. All right, so I think that being in the kind of business you are, your experience comes into a lot of the decisions that you make. You do rely on experience and intuition. Intuition is really just, lots of experience that has been confirmed. So do rely on that, because, from a study that I was involved in, when we solicited feedback from doctors who have experienced breaches and cyber attacks, in the majority of cases, they all said, I felt that there was something up. I felt that there was something not going right. So trust your gut like you do, in your treatment regime. And thank you very much. I think that, I'll wrap up there. If you do ever end off in some serious trouble, we are available 24/7, so you can look out to contact us. My team and I'm actually in the office now, just checking in. The night shift is walking in. So yeah, we're always on standby.
Thank you, Surin. That was so helpful and really good practical points. Brandon, can I ask you to put us all on the screen as panelists? There's some great questions and comments coming through, and we're going to move over to a panel discussion. Surin, do you want to stop sharing on your side? There we go. Yep. Dr. Strawn, I'm hoping that you haven't got an emergency on your hand, but we'll wait for you to join. There was one question here, Surin, which I think may be very helpful for you to answer in the Q&A, about, is remote access via VPN to the practice servers vulnerable?
Well, so yeah, I think that maybe that's maybe the wrong question, but I'll answer it anyway. So when we think about how we connect into resources, think of it like this: you need a particular book in the library. The only way for you to get to it is to ask someone to go to that shelf, pick up the book, and start reading off the pages for you. That's effectively what you're doing each time you're accessing something remote. Now, that something remote could very well be a server sitting in your practice, and you now want to grab some notes off it in the middle of the night. Very much the same thing. Now, in that same example I give you about the library, you want to test which elements of this connection are secure. Now, a VPN does very well to protect you, but it's not a complete protection, right? It's going to give you a level of protection in terms of how you're connecting. you're also going to have to, ensure that the device you are connecting from is also a device you trust. And on the other side of the transaction, the device you're connecting to, is that secure? And is there any possibility that that device can infect anything tried to connect to it? So, and if you not adopt that principle of zero trust, you'll understand why I start looking for various choke points and not just the obvious one piece of technology that I'm using. So, short answer, VPN usage is good practice, but let's also look at a few other elements like antivirus, regular scanning, vulnerabilities, patching, how you manage your identity and access management, who has what level of privileges, can anyone just get onto your server and jump into a patient record? So, you'll find that technical controls are kind of half of the puzzle. The other half really is around training, which ultimately manifests in behavior. My biggest challenge is not the tech. It's the hackers, obviously, but it's also how my clients behave, which is generally badly. They treat information like it is, isn't really worth that much until they have a breach.
Thank you so much, Suren. That was really helpful. Shlumbi and Dr. Strawn, I'm looking at this question from Alison Matham about what's happening on the ground in the chat. And I'm wondering whether that's something we should address. What are we seeing?
Yeah, I think she's just highlighting an issue. I think it's an important issue because it's about the requests that we get as healthcare professionals for patient records. Now, the one that happens all the time is a funder saying, send me your patient's records because there's a bit of an inquiry about the bill and we need some verification on that. Now, what's interesting is that in the HPCSA ethical booklets, that it says that the scheme has the right to ask for the patient's notes. That's what it says. It doesn't say that you must then go and get consent from the patient. If you ask the scheme about it, the scheme's going to go that the patient signs a consent release form with us when they take out the policy document. But you can imagine how small that print is and that the patient probably didn't even know they were doing it. So Kate will tell you, I'm sure she will, that regardless of what anybody tells you, get consent from your patient. So if there's a billing house running around trying to take sample data, you don't give them anything. Kate,
Not a thing.
Hey?
Not a thing, ever. Patient consent, whenever you're worried about sharing patient data, patient consent form, always. You can protect yourself ahead of time. So if this is a patient of your practice, when they become a patient of your practice, when they sign their initial forms, signing up with you as their doctor or their primary practitioner, in those standard terms of conditions, things to think about to include is, for instance, a medical aid audit that comes through your doors, that they consent upfront to you releasing information when a medical aid audit comes in. But absent that, every single time someone asks for records, you need to check that you have a consent or should you be getting a consent. It really is a huge problem that we face daily.
Maybe I can just, and this is a discussion for another day. It's not for, maybe it's another webinar on its own. The problem with all of what you're just saying, Kate and Simon, is you refuse giving those records for a managed care company or the scheme, they stop paying you. They just stop. Yeah. Even though you understand that, look, from a regulatory point of view and all of that, now you put practitioners or they put practitioners in a situation where they've got to break this law because they are not going to get paid. I mean, the power is with the funder. That is why I'm saying, as much as we understand the regulations, we understand the law, we understand what should happen, but there are practicalities on the ground. That's a webinar for another day. I just want to have one comment from Suren's presentation. And for me, the comment is, if you looked at our introductory questions, the majority of people who are attending today said, I don't use real telehealth. It's because, someone had not presented to say email, to say WhatsApp, they're part of telehealth. Now that that has been presented, if we were to ask that same question, you may find that the majority of people would have changed, because now they understand that actually, radiology reports, pathology reports, they come via emails. They communicate with patients via emails. They communicate via WhatsApp with the patients that they know. So it's an understanding. The second thing that I just wanted to say is when Suren was presenting, I felt like a patient who's listening to a doctor, where I just understand maybe 5, 10%, 3% of what he's saying. The rest I don't understand. So my point really is, it is very clear that we all use in our practices more than we think we do. And my advice from this webinar is that maybe we need to get people who are cyber, in your practice, talk to a cyber specialist or a person who understands this. These encryptions and all end-to-end, it's Greek to us, or it's medicine to patients. Therefore, it becomes important for the practitioners who are attending to ensure that you understand that whatever you are doing, there is a cyber risk, and also look for cover. Because all these things are pushed by patients more than being pushed by you as a practitioner. It's the patients that would push you. If you say to a patient, I can't take a call, come to the practice, I can't respond on WhatsApp, what are they going to do? They're going to go next door. Get a cyber specialist, inquire around the market, and look for cyber cover. That's basically my advice, because I'm also don't understand what is going on.
Shlombi, that was
Yeah,
so helpful.
I noticed, Suren, it was, I mean, for me, it was one of the best presentations that I heard, because it was the only one I've ever heard where I haven't come away from it feeling doom and gloom. And then I'm about to go to jail tomorrow because my systems are so weak that somebody's going to catch me, So I liked your statement. What you actually written there, if you can't afford cybersecurity, you can't afford a breach. And that was you. You had made that statement. I saw that.
Yes.
So Shlombi's right. I mean, it is that. I think that when we're talking about this now we're talking about cybersecurity in terms of the information and the security of the entire platform, let alone the weaknesses we expose ourselves to in the way we deal with patients. Now, what I'm trying to say here is when you're face to face with a patient, you will make every effort to ensure that patient, because you're looking them in the eyes, understands you, understands the prognosis, understands that they have your contact details, and understands what your expectation is. And you would generally say to them, so this is what I expect, blah, 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 blah. If that doesn't happen, get back to me. But we don't in social media, and certainly not on quick WhatsApp messages, offer that same level of detail, Shlombi and Kate, in terms of medico-legal, because the patient's going to go, you never told me to come back if that happened. You just gave me advice and left me to my own devices. So that's why going back to it, to what the guideline is saying, is that try as much as possible to treat it like you are face-to-face with the patient, like you would if you were having a proper video consult.
Yeah. The other thing that I picked up on as well is the fact that we open ourselves up to, or you guys open yourselves up to, actually me as a lawyer too, you open yourselves up to these different platforms to engage with patients on. Failure to respond to those patients, I mean, that's going to result in HPCSA complaints too. The failure to respond to that WhatsApp. Now you didn't respond to me for 2 hours and now I'm in an emergency room. I can picture an HPCSA complaint coming in like that. So if you have a platform that you're using to communicate with your patients, like, it needs to be an efficient platform. You can't leave patients hanging in the same breath. We know that patients know what their rights are these days. HPCSA complaints are easy. I mean, AI generates them these days, is what we see. So patients are so quick to complain that if you are going to have these platforms, it needs to be efficient.
Dr. Strawn, it brings me back to your conversation, your comment at the beginning of the session about a patient seeing a blue tick next to their message. And now what? Like, you haven't responded, you're busy, you're consulting somewhere else, and the patient takes it that maybe you don't care. But don't want to treat them. Yeah, there's so many options. There's so many options.
There was one other question on the chat that we didn't get to, and I think it may be
Yes.
worthwhile just looking at.
Yes,
And the
please.
question was about just downloading the WhatsApp chat and including that in your notes. Is that actually enough? So, and I'm going to expand on that question to Hlombi and Kate to say, do you even have to download it? Can't you just record in your own words? Because the way I look at it is, if I'm face-to-face with a patient, I'm recording notes about that. And at the end of the day, there is no record of that other than what I have written down in my clinical notes. So if I've interacted with a patient, regardless of the platform, as long as I've recorded accurate notes and dated and time and all that kind of stuff, doesn't have to be that original text. But I also understand completely that the patient who's going to lay a logic complaint against you, they are definitely going to have that version. They're going to come and say, this is exactly what happened. And then if you just got your written, so let me hand that over to you and see what your thoughts are.
Yeah, okay, I think you answered it perfectly there. I mean, recording what you said in your clinical notes is sufficient for HPCSA guidelines. It's the same as a telephone conversation you have with a nurse, with a fellow colleague, or with your patient. You record your notes saying telephone call with nurse, ordered this, ordered that, confirmed vitals as this, confirmed vitals as that. That is your note. But you do run the risk then of not having the actual source document, especially if it's in written form. So if a patient then comes and says, well, here is the WhatsApp, and you wrote down the incorrect version of what was actually said, that's going to be problematic long term. If we're talking about liability and potential complaints at the HPCSA. But I don't think it would be frowned upon at all for you to transcribe what was said in your WhatsApp call, WhatsApp message, just like you do a call.
Yeah, Amy, if I may, there's, I think
Yes.
a simple principle to adopt is, treat your device like your practice, or your consulting room. Your device has now become another place where you are consulting. So that's one thing. The risk, and Amy, you said this, but the risk now is increased because that convenience factor becomes a risk multiplier. So accept that. My sort of simple advice around using WhatsApp is use it for speed, not for record keeping. As soon as you are approaching a clinical decision and you're starting to see I'm exchanging information that would be considered sensitive, and sensitive in the category of POPI is privileged personally identifiable information, being, a simple thing like a wound picture on WhatsApp with the patient's being identified is already in breach. So, I think we're having far fewer failures in technology and breaches as opposed to failures in judgment. So, all of this is really advice and guidance, but ultimately you will make that final, judgment call. And if you can, move to more formal platforms as quickly as I said, use it for speed, not record keeping. And I agree with the guidance given here. If you're transcribing or recording it and kind of making a copy of the core information, that would be adequate.
Thank you, Suren. And the rest of the panelists for commenting. And it's great. We're getting some lovely feedback, people saying from the audience that this has really been helpful. I'm going to suggest that we go to our last case study now, because I think that adds a different dynamic into our telehealth space. So let me go back to sharing my screen. All right. Let me just go into slideshow mode. Right, so that should now be all good. Hlombi, if I can hand over to you to introduce the case for us, please.
Thank you. I just thought that, if we were pilots, you can hear pilots talking about reaching 36,000 feet and turbulence. We are reaching turbulence at the moment with these case studies. So this is a case study that I don't even know myself. Mrs. D, aged 67, type 2 diabetes, hypertension, COPD, admitted in a private hospital with pneumonia under Dr. A, and Dr. A approved her discharge to a hospital at home program that is overseen remotely by doctors in a registered home care company via a digital platform. The program promised hospital-level care at home, including daily nursing visits, remote monitoring, 24-hour physician oversight. Nurse sister conducted daily in-person assessments while monitoring via the digital dashboard. On day one, Mrs. D and her daughter signed a brief electronic consent form facilitated by a hospital administrative officer. Day 2 and 3, the nurse noted mild breathlessness and a productive cough, but recorded vitals as within normal limits and did not escalate concerns. That night, the monitoring tablet failed. I think that was the time of load shedding due to flat battery and no data was transmitted. Let's go to the next one. Day 4, the daughter called the home care company to report lethargy, breathing difficulties, and a non-clinical person recorded that as a routine update. Doctor only reviewed that information the following morning. Day 5, the nurse found Mrs. D cyanotic and unresponsive. She was readmitted and died 2 days later. Family filed an HPCSA complaint and took legal action via the civil route.
Thank you, Shlombi. Okay, so let us go into our questions. Oh, and now it doesn't want to move. Okay, oh, hold on. There we go. Sorry. All right, so case study 3, question 1. Which statement best reflects the ethical requirements for obtaining informed consent in the hospital at home program? A, consent is vital if signed electronically, and it is the patient's responsibility. Whether the family understands the implications of hospital at home or not is immaterial. B, consent is ethically sufficient if the patient's condition appears stable and the patient signs it at the time of discharge. Or C, consent must be obtained through a transparent and clear, comprehensive process that includes risks, benefits, and limitations of remote care. Brandon, can I please ask for you to bring up the question for us? All right, so you're welcome to vote, or maybe I should say I invite you to vote. If you are joining for the first time and this is your first case study, if you are unable to vote, please feel free to put your answers in the chat. I can see a few comments coming through there. Looking good, looking good. We're going to give you a few more seconds to answer. And it looks like the majority are going with option C. Okay. All right, Brandon, will you close the poll for us, please? And let's see. So the correct answer is C. Consent must be obtained through a transparent and clear, comprehensive process that includes risks, benefits, and limitations of remote care. Okay, thank you. Right, let's do question number 2. Who carries ethical responsibility regarding remote monitoring failure, such as the flat battery incident? A, the home care company and doctors. B, Dr. A, as the one who approved discharge to the hospital at home program. C, the nursing sister. D, the hospital. Or E, the manufacturer of the equipment. Brandon, can I invite you please to share the poll for us? Okay, once again, take a vote. Remember, it's anonymous. So even if you're not sure, give a guess. Okay, interesting voting coming through here. Fast and furious. Okay, we'll give a few more seconds for the last few to come through. All right. Brandon, if you can close the poll for us. Okay, so 63% voted option A, and we are specifically not identifying the correct answer here because we're going to discuss it in the panel. So panel, if you'll just notice the answer that has been selected. All right. And then lastly, question 3. What ethical breach occurred when the daughter's call was logged as a routine update? A, the non-clinical staff may log updates without escalation if the patient is already under observation. B, escalation should be based on logic, not just clinical reporting, unless the patient is in visible distress. And C, failure to triage a clinical concern through a qualified professional may constitute negligence in the duty of care. Brandon, can you bring up our last poll, please? Right. I can see some answers coming through on the chat as well. Okay, majority are choosing option C so far. We'll give you a few more seconds to answer. I'm seeing some comments coming through on the chat, which is great. Okay, a few more seconds here before we close. Okay, Brandon, if you can close this poll and bring up the correct answer for us. Okay, and the majority of you, 99% of you, voted for C. So the failure to triage a clinical concern is the correct answer. Well done. Okay, so we're now going to go through to another panel discussion. So I'm going to stop sharing. Brandon, if you can bring all the faculty through. Wonderful. That's looking great. So should we discuss question number 2 about who is responsible? Because that is a nuanced gray space.
Yeah, I think we should talk about the consent issue first. I think we had just for the audience's information. We as a panel had a discussion about whether we should include this new thing in South Africa. There is no real guideline on it. There's certainly no training. Nobody's trained to deal with this remotely, and not many people understand the complexities. I mean, the functionality of it. Because not many patients have actually even been used hospital at home. I know in the discovery space, maybe 400 patients. But there are layers of consent that are necessary here. There's obviously consent that has to happen from the home care company that is doing the remote monitoring. But the doctor who is discharging the patient needs to be able to consent to it. And Kate, the interesting thing here is that your care into the monitoring care of somebody else, but they've got to consent to that, and yet you've still got oversight and carry the final responsibility. And in terms of the artificial intelligence guidelines from the HPCSA, if there is any AI being used in any of those monitoring devices and dashboards, and we know that some of them do have algorithms, that the discharging doctor has to know about those, has to know how they work, and has to be able to explain to the patient the accuracy, the reliability, the bias, it's just layer upon layer upon layer of stuff that we have to. I think that's the important thing, is that there's layers of consent here.
Yeah, I mean, this is a tricky one. I mean, but like you said, there's so many people involved, so many layers involved, that you really do need to understand the matrix in which you're working. You need to understand what the different contracts say, who's given consent for what, where, if there is this person A to person B to person C, and then the patient is only really seeing one person in that chain. But that doesn't exclude liability through the entire chain. And that's the tricky part about this scenario, is that it is a difficult aspect to deal with. This, what do we call them? The hospital at home company is providing a service. They're likely to have included in their, I mean, obviously we're talking a hypothetical company, they're likely to have included in their terms of service certain consents, indemnities, but as a practitioner, you also need to understand what those indemnities and consents entail. So you can't be oblivious. You can't throw your hands in the air and say, oh, I didn't know that, or I didn't appreciate it. You really have to educate yourself and inform yourself as to the matrix in which this hospital at home scenario operates.
I mean, basically, is it true to say that just in looking at the Consumer Protection Act, I mean, everything in that value chain is exposed.
Everything.
And you, as the doctor who has discharged the patient into that care, you are liable. They underperform just in the Consumer Protection Act. Is that correct?
Correct. Yeah. I mean, you are a consumer, a patient doesn't have to go after the end provider, the hospital at home. All they have to do is they have a familial relationship or a patient relationship with their doctor. That is the point of contact. It's just like if a product fails on a shelf you buy from the store, that product might have been manufactured and imported through 100 different other companies, but all they have to sue is the person that they bought that product from. And it's the same setting here. That person, the doctor, that first point of contact, has an opportunity to join other members in that chain to the litigation or to the complaint. But being the person who is actually face-to-face patient-doctor relationship with that patient, you're the first in line. And that's why you really do need to understand the matrix that you work in.
Yeah,
I'm really curious. Sorry,
there are,
Shlomi, go.
sorry,
Suren?
yeah, there are names to these layers that you're referring to. So, you're actually asking for consent across three different things when it comes to telehealth. The first thing is the mode, so there has to be an awareness of the medium we're using. The second is the clinical layer, the clinical consent layer. And the third is the data and privacy layer. So, we kind of jumble them all together, but they actually are discrete. And Kate makes a good point. Yes, you also have to consider that it's not just POPI and it's not just your other regulations. You've got to even consider something like the Consumer Protection Act. So lots to take into account. Unfortunately, not an easy space to be in right now.
Shlomi, did you want to say something?
Yeah, I wanted to actually then we've got to take a step back here and have a look. That step back is initially the relationship, it's the doctor and the patient. In this whole chain, if anything goes wrong, the patient would always go back to the doctor. The doctor would always be involved. In some cases, Kate would probably know this. In some cases, they will not even cite the other company and whoever else in the summons.
They don't know who to sue.
They don't know who to sue, but they know that they will sue the doctor. That part is very clear. So for me, the pressure and the difficulty here, and I'm going to give maybe an advice. The pressure and the difficulty is, in this case, Dr. A works in a certain private hospital. That hospital would say, this patient has been in this ward now for 5 days. And this patient now probably needs to go to a hospital at home. And you are handing over that patient from a pressure of the facility where you are at, because you need to remove this now. This bed needs to be occupied by someone else. Now the hospital puts pressure on you as the doctor. You are handing this patient over to the hospital at home program, maybe to another doctor, or you participate in that program. And maybe there's an incentive where, if now you are consulting via the digital platform, you get paid 2 rands more. So the advice for me, because this is a new thing that is coming to the market and it's not really going to go away, is you need to protect yourself first as a doctor, but you do not know all the nuances. For instance, what Kate, you're talking about in terms of the equipment and all other things you do not know. My advice is contact your insurer, ask for advice, proper legal advice. It will give you exactly all the questions that needs to be asked before you enroll, if you enroll in the program. I can't give you any advice on it because I don't really know, but if I were in your position, I would ask and say, let me contact my insurer and ask what is it that I need to look at in a situation like this one.
Thank you for those sage words, Shlomi.
Yes.
Kate, over to you.
Yeah, you're not going to be thrown into this, like you're going to have to sign up for this, right? You don't have to do this program. You're as the doctor, I mean, I don't know the pressures being faced by medical aides, which is obviously being raised in the chat here, but it's still a choice as a doctor how you engage in this new aged form of healthcare. But there will be contracts in place. There will be terms and conditions in place. And as a doctor, just like me as a lawyer, I don't know the medical side of things. As a doctor, no one expects you to know the legal side of things. That's why relying on your insurer for that feedback is so important, because there could be indemnities in place in respect of the terms and conditions that could prejudice you. And without understanding the legal framework within which you are acting, you're not going to understand the risks. So do reach out to your professional indemnity insurer.
Other thing,
Thanks,
Kate
Steve.
Schlumby, is that some of the funders have a hospital at home policy for lower options in their medical aid. And if in their case manager's determination, the patient fits all of the required clinical metrics and has a suitable hospital at home possibility, and they declare that that patient is fit for hospital at home, and the patient chooses not to, or the doctor chooses not to, the patient has to pay a copay to stay in hospital.
Sure.
So, I mean, the
Yes.
pressure on our doctors is absolutely massive.
Mm.
So, but maybe we should move on to that second one, because I know we're running out of time.
Yes.
There have been quite a few comments here. So, I think if I just try to explain quickly through that scenario. So, in that scenario, what would have happened? What happens is in a hospital home situation is the home care program has doctors who monitor the metrics coming from the patient, all the data on a 24-hour basis, just like Serene's team are doing, sitting in his office now. They monitor 24 hours a day. So if there had been breathlessness, if there had been a fever, if there had been tachycardia, they would have picked it up and responded. If a battery had gone flat, they would have seen the thing was done. So this is very unlikely that would have happened, because it would have been picked up by the people watching the patient 24 hours a day. That's why the doctor who discharges the patient there, I mean, they literally they're not going to get that information. It's not sent to them directly. They can obviously access it as and when they need to, but it's not necessary for them to watch it 24 hours a day, because there are other doctors doing it who assign a contract who will then escalate care if needs be. So what I did was send the scenario to one of the largest medical aides who's driving hospital at home, and asked the head of the hospital at home program what they thought of the scenario. And they said the answer was A, in terms of the flat battery. It's the hospital at home, because they supplied the equipment and they are monitoring the patient, and they should have noticed, therefore, that there was no information coming from that machine and should have reacted. So that's what the answer was, yeah.
Thanks very much, Dr. Strawn. And I can see that there's lots of questions still coming through. And I'm also noticing that we're 2 minutes over time. Shumbi, can we move towards closing?
Saying that I like the answer that, look, the one that is responsible is A. Unfortunately, the patient knows Dr. Strawn.
Yeah,
All the patient will start. They will start and send you to the HPCSA. Are these hospital at home things? I think there's a question like that. Regulated? Is there any regulation that's looking after?
Yeah, they're regulated under the managed care organizations. But
from a HPCSA or from a Office of Healthcare Standards or another state thing?
We've approached HPCSA has got no guidelines on this at all. And when I spoke to the registrar about it, he said, well, this is why we're here. If there's an issue like this, bring it to us and let's have a look at it and let's see if we can create some guidelines.
But so just one last point, just because A is the answer does not mean that the doctor is not sued. That's or a complaint is lodged. Right. And that's the important part to take home, is it doesn't mean you're out of the equation. These equations can last very long.
So that's a very important point. We make it all the time as healthcare professionals, because we get told all the time, Ben, it's not your fault. Clearly nothing's going to happen to you. And you go, but yeah, what we're trying to avoid is getting the case in the first place, having to defend ourselves when we know that we didn't do anything wrong, but we don't even want to have to defend ourselves. So don't put us in that situation. That's the argument here.
It's been wonderful, this discussion, and I can see I've even made a note for myself that this is a potential topic to come back to in a future webinar. Dr. Strawn, can I ask you to share some key messages for tonight, and then we'll do our thank yous? Yeah,
so I think for me, the thing here is that we need to examine our risk. We have to manage our exposure, and we have to be very aware of the strength of our security systems. There are things about practicing medicine and looking after patients and working in teams where we have to be available to give advice to somebody who is asking for it, or to interact with a patient because they can't get to see you and it's a quick thing. These things are never, ever going to go away. And these guidelines are very stringent in what they're doing. But I think that there is still scope for us to practice the way we're practicing, but to do an audit. Suren was saying, have a look at the way that you practice. Look for the weaknesses, fill in the gaps. And sometimes you have to make those tough calls and say to patients, I can't talk to you about this. You have to come in and see me. This is not something, or this conversation has gone as far as I'm prepared to take it. No, you can't send me a photograph of that part of your child's anatomy. Rather, bring it in so I can see the real live version of it. It's things like that where we have to understand it. And then I think also that if we are the ones reaching out to colleagues, so if I as a general pediatrician reach out to a neonatologist, we must be very sure that we're not putting our colleague at risk. Be sure that you are well prepared, you've got a secure platform, that you know what information you're going to make available, that you're recording all of the information, and that you're not kind of throwing them under the bus just by saying, spoke to Dr. X, thanks very much, and then they still know who I am, so they'll sue me at the end, as Tommy always says. So I think that's what it really is. Let's use these guidelines as the trigger for a very secure thought process about how we're operating and what we need to manage our risk. Thanks, Amy. That's what I've got to.
Wonderful. Thanks very much, Dr. Strawn. So what I just want to do is share the contact details for the faculty, just in case you'd like to contact them for some more information. Sometimes they may refer you to someone else, but their emails are available, and their contact organizations are listed. So please reach out if there's anything we can help with. And then lastly, some thank yous. So thank you to the panelists and the faculty tonight for all your preparation. Thank you to the audience, you guys have been wonderful. Thank you for all your questions and your engagement, and answering in the polls. It's been super. Please complete the post-evaluation webinar so that we can get some feedback on what we're doing right and where we need to improve, and anything else that you feel that we should know. From a CPD certificate perspective, you will be receiving these in due course, and just from an interest sake perspective, there are some interesting developments that EthiQal will be announcing in 2026. And yeah, there are even some rewards for attending webinars like this, other than your CPD points. So keep posted for that. And for those of you who want to come back and watch the recording, or to recommend it to a colleague, the recording will be available on the EthiQal website from Thursday, the 18th of December. Brandon, if I can hand over to you to start our outro video. Faculty, wishing you a wonderful evening, and thank you to everyone who joined tonight. Enjoy the rest of your evening.